right, so for our observation, we're going to first undrape the patient, and we're looking for visible edema or any signs of scars, moles, or anything that's abnormal that might mess with our readings. Okay, for our instrumentation, we're going to be using the nervous scope. First thing you want to do is make sure that it's on, and then make sure that it's set to the most medium setting. Since we're doing the cervicals first, we're going to make sure that the arms are brought in slightly. We're going to be tractioning from inferior to superior, making sure that there's no breaks, it's perpendicular to the spine. As we go up, we're going to make sure, looking to see if there's any deviations from left to right. If we find any, we're going to repeat at that segment 3 times and then mark below. So for the thoracics, it's a little bit different. We're going to bring out the arms a little bit more, but keeping it the same, going from superior to inferior, making sure that it's perpendicular to the spine. We're going to go for thoracics all the way down to lumbar and sacrum, checking to see if there's any deviations. If there are, we're going to find that segment and repeat 3 times. That's it. We're going to be doing static palpation. First, we're going to go ahead and run our fingers down the spine, looking for edema and seeing if there's any a boggy feel or any soft squishiness. And then we're going to challenge the spinous process as well, seeing if there's any pain on palpation. And then we're going to go head all the way down to the SIs. Now here, if you have pain above the SI joints, it's going to be indicative of PI pain. If it's below the SI joint, it'll be indicative of AS pain. And if the whole joint is tender, you're going to have a possible EX. And if there's no tenderness within the joint, it could be indicative of IN pain, but that's only if seen with deep inguinal pain as well. Okay. So for our motion palp section, we're going to go ahead and motion palp the cervicals. Starting off, we're going to palpate down to about C3. And from here, I'm going to place my chiropractic index shift on the segment that we're challenging and my IFT above, as well as my ring finger on the segment below. We're going to take the head into flexion, feeling for the spinous processes to open up, and in extension, feeling for them to close down. During flexion, if the spinous processes don't open up, then it's indicative of a flexion restriction. And if in extension, if the spinous processes don't close down on your finger, it's indicative of an extension restriction. From here, we're going to go ahead and rotate the head right and then left. So for our motion palp section, we're going to go ahead and motion palp the cervicals. Starting off, we're going to palpate down to about C3. And from here, I'm going to place my chiropractic index shift on the segment that we're challenging and my IFT above, as well as my ring finger on the segment below. I take the head into flexion and then extension, feeling for the spinous processes to open up. If they don't open up, it's an indication that the segment went posterior. So for this part, we're going to go ahead and rotate the head to the left, feeling for range of motion. And if there's a decreased range of motion, it's going to be an indication that there's a restriction on that side, as well as the right. And from here, we're going to go ahead and challenge the lateral flexion. So I'm going to laterally flex to the left and then to the right, feeling for the curvature of the spine. If we don't feel that and it feels flat or like the vertebrae are stacked and they're not moving, that can be a indication that there is a restriction for a superior or inferior portion. So for our next segment, we're going to go ahead and motion palp the atlas. We're going to start off with the mastoid, and we're going to drop right off onto the C1 vertebrae. And then I'm going to go ahead and make my contact point in between C1 and C2. And from here, we're going to go ahead and laterally flex the patient's head to the side for contact, feeling for the TVPs to close down. If they don't close down, then that's an indication that the atlas has gone lateral to the side of contact. Okay, so for this next portion, I'm gonna ask the patient to stand up for me. All right, go ahead and close your eyes and tilt your head up and down. So I tell you to stop. All right, go ahead and stop. So she looks pretty neutral, but if her chin was elevated up a little bit, it would be an indication for AS, or if it was pointed downwards, it would be an indication of an AI. So for this last portion, we're gonna go ahead and test the posterior or anterior portion of the atlas. I'm gonna make my contact, again falling off the mastoid onto C1. I'm gonna contact C1 and go ahead and rotate the patient's head away from contact, pushing P to A, feeling for a restriction. If it's hard, that's an indication that the atlas has went posterior on the involved side. So for this next section, we're gonna go ahead and motion palp the occiput. I'm gonna start off with palpating down to the mastoid, falling right off in between the mastoid and C1. I'm gonna go ahead and laterally flex the patient's head down to the right side of contact, feeling for the mastoid to close down on C1. If I don't feel that the mastoid is closing down on C1, that can be an indication that the occiput has gone lateral to that side. Okay. For our next portion, we're going to go ahead and challenge the P to A and A to P glide in the occiput, starting off with the P to A glide. I'm going to take a calcaneal dinar contact over the posterior superior portion of my patient's ear. We're going to isolate the side where laterality, so we're going to isolate the right side for this one. And we're going to push P to A, feeling for a springy infield. If we do not feel that, then that means there's a restriction on that side of PS. So we're going to kind of do the same thing for the anterior portion for the A to P, except we're going to go ahead and take a contact with a pisiform contact over the right superior orbital ridge. I'm going to back it up by cupping the calcaneus. We're going to bring it in extension, flexion a little bit, and I'm going to challenge from A to P, feeling for springy infield. If I don't feel springy infield in that portion, that will also indicate that it's a AS subluxation. For the last part, we're going to go ahead and challenge the P to A rotation component of the occiput. I'm going to start off kind of like we did for the laterality portion. We're going to drop off the mastoid right in between C1, above C1. And we're going to go ahead and rotate the patient's head away, feeling for the mastoid to either leave or stay. If it leaves, then there's nothing wrong with it. But if it doesn't go, then that means, or it doesn't leave and you feel it's staying, means that there's going to be a posterior restriction on that side. All right, for this section, we're going to go and motion palp the SI joint. I'm going to place my IFT on the PSIS, and my SIFT is going to be on the sacrum. I'm going to rotate my patient towards the right, feeling for movement within the SI. If there is no movement within the SI, that would be an indication for a right ilium subluxation. Okay. For our next portion, we're going to go ahead and challenge the PSIS. We're going to find the PSIS first, right here. I'm going to go slightly inferior and tissue pull up. I'm going to ask the patient to bend forward for me. And as you can see, her right side went up, which is an indication of a right subluxation. Now, if the right side went up and then the left side followed afterwards, it would be an indication that it was a subluxation within the sacrum. Okay, for this segment, we're going to go ahead and evaluate the PI or AS component within the ilium. So first, we're going to start with observation. I'm going to go down to the gluteal fold and check to see if any asymmetry. As you can see, the right side is higher, which is an indication that you have an AS ilium on the right side. Now we're going to go to the mechanical portion. You're going to take a contact on the right PSIS and S2 tubercle on the sacrum. I'm going to ask the patient to raise their right leg. Now, I'm expecting to see my right side or valve side thumb to go posterior and inferior. If it does not, that's an indication for a AS ilium. I'm going to ask the patient to lift their left leg up. I'm looking to see if my thumb on contacting the sacrum goes inferior. If it doesn't, that's an indication that it's a PI ilium on the involved side. Okay, for this final SI component, we're going to be challenging the EX or IN portion of it. So we start off with observing the gluteal width. We're going to go down to the gluteal clefts and bring out. So these look pretty even, but if you had a, say we had a right narrow side, it would be a EX component. And if we had like a wide left side, it would be the IN component. Could you sit down for me, please? We're going to now move to the mechanical portion of this. So I'm going to go ahead and place my fingers within the SI joint. I'm going to bring the leg out laterally, feeling for closure down within the SI joint. And I feel it move. If I didn't feel it move, it would be a EX subluxation. I'm going to go ahead and challenge it the opposite way. We're going to bring the leg more medially, feeling for the joint space to widen. If we didn't feel the joint space widen, it would be a IN subluxation.